With the exception of pattern recognition, pretty much any approach to diagnosis is based on generating a hypothesis, if you can do anything organised or rational at all. Pattern recognition isn't. Pattern recognition, you know what the problem is within a few seconds of seeing it, so you've already made the diagnosis. But otherwise you need a hypothesis, and this is almost entirely based on local anatomy. So you need to know what's going on under the skin, and on the skin actually, of the area you're dealing with. So we're going to use tennis elbow as the example all the way through this, because it's nice and common and everybody understands it, and it works really quite well to get all this done. So the local anatomy here is necessary, knowledge is necessary, and you work from there. Now this will lead you to your hypothesis. You'll pick one of those structures. Most probable, you can go with that. It's quick, it's easy, well, quicker and easy as it's got to get. And you're in now if that most probable one is there, which it probably is because it's most probable. Otherwise you're going to have to go through them in descending order of probability. Or you can go for the most serious pathology, which we really don't have for the elbow, but if you're working in the spine, for example, especially the cervical spine, you've got a number that you have to be concerned about. We'll talk about those as we go. So you go for most serious to get it out of the way, and then get on to the more mundane, less serious problems that are not going to threaten the health. The other way you can do this is negative differential diagnosis. And I think this might be the best way of going for when there's multiple things it could be, rather than positive differential diagnosis where you're trying to prove each one. This one, all you have to do is find one test or one question that disproves it. Much easier, probably more reliable as well. So let's have a look at pattern recognition. The pros for this is basically that it's probably going to be right. If you're an expert in the area to the point where you understand what's going on rapidly, then you're probably going to be right. It's unusual for that to fail. I will talk to you about that, why pattern recognition fails in experts when they stop striving to improve, but we'll come back to that. It's very fast. I mean, very, very fast. It's estimated that an expert physician knowledgeable about the subject that's coming to see him can make the diagnosis within 15 seconds or so. There's no reason why we wouldn't be doing the same thing here with our area. The cons are bias and error and performer. Now, experts get there by quality experience. That is by being skeptical, always questioning, always looking for a different answer, and going that route. So you're never overly confident in what you're saying, and you keep on striving to get better. If that stops, and they become infallible, as it were, they think they're infallible, then they go right back to Dunning-Kruger errors and everything else. So you can have somebody, and these are the ones who are these are specialists who can be very arrogant. Now they can be arrogant and good, or they can be arrogant and bad, but at one point or another they were expert, but they stopped questioning their own judgment, and these become dangerous. So the cons of that is exactly that, so bias and error, and this has got to be corrected for. So it needs bias correction. That's done by differential diagnosis, generally by positive differential diagnosis, but it can be done with negative, and done quickly with negative, and maybe completion of the full examination if there's a risk of premature closure. Now, just a word on positive differential diagnosis. I'm saying that it's really cumbersome. However, if you're a physician, for example, in fact it works for physicians because of this, and you can order half a dozen tests, each test will establish the differential as the diagnosis, then it's not cumbersome, you're just waiting for the results of the test. But in our case, where it's based on a clinical diagnosis, clinical assessment and diagnosis, then that becomes very cumbersome because you've got to do a whole bunch of tests for each differential. So negative differentials overcome that, and I think probably do it with less error than does positive differentials. Let's look at the process for pattern recognition. As I say, the diagnosis is made. This is not hypothesis, you made the diagnosis. Now, in this case, lateral elbow pain, it may well be common extension tendinopathy. So you run checks, at least a good expert would do. And this could be as simple as pain on gripping, palpation of the tendon, or isometric wrist extension, or all three. It doesn't take very long at all to be sure about this. Given that, then you've got your diagnosis. Make sure you haven't got a bias problem, if you need to. So you can do a negative differential diagnosis on your diagnosis and make sure, and you're good to go. Now, generally speaking, with pattern recognition, you don't do the bias correction, because if you've done that first check on your diagnosis, basically you probably don't need the bias correction, because the checks plus your expertise and recognition of this problem is enough usually. Okay, so that would be the process of pattern recognition. Now, obviously, local anatomy isn't about the diagnosis, but you need a good appreciation of the anatomy underneath the pain. So, if for no other reason diagnosis, and it's certainly not the only reason, you need to buff up your anatomy almost certainly. So, the local anatomy over the elbow is skin. So it's unlikely to be a major problem, but you could be looking for rashes, cuts and so on, but bruises come to that. It's unlikely you're going to see that. Subcutaneous fat is also not going to be a major issue for you. The epicondyle. Now, I know it's called lateral epicondylitis, but we talked about this, and it's a stupid term for it. The bone isn't involved, it's not inflamed anyway. And it's just ridiculous. But if you worry about the epicondyle, possibility of a stress fracture, which are really rare, then you can palpate the epicondyle. Common extensor tendon, you need to know about that, and that's probably what it's going to be. The joint itself, radial head, ulno-humeral joint, all of this can give lateral elbow pain. The lateral collateral ligament, traumatic or a degenerative tear. And of course, it may be referred as well, causing the lateral elbow pain. So all of this has to be considered when you're making a hypothesis. Okay, so we're going to generate a hypothesis. One way to do this is most to least probable. You can also go least to most probable. Most people will do most to least probable. I'll talk about why in a minute, why we go least. So most to least probable, the one that's most probable is probably the one you're going to find. I mean, it's written on the can, isn't it? So the most common one, I think, is going to be a tendinopathy, common extensor tendinopathy, in particular tendinosis. Then biomechanical dysfunctions, usually ulno-humeral and then radiohumeral, but it can be radio-ulnar as well. Arthropathies, other than biomechanical dysfunctions, arthritis, arthrosis, possible articular surface fractures and so on, or even loose bodies inside the joint. Degenerative tears of the lateral collateral ligament, stress fractures. Although they're very rare, they can occur. So if you go from least to most probable, you'll go through all of these before you hit the positive one, almost certainly. So that will eliminate bias. The other way will eliminate the time you'll spend doing it and the amount of effort going into this. This is tiring if you're going to investigate every single differential diagnosis to prove it. So generating H1 from the most serious conditions possible. Now, in the elbow, that's not going to be a major issue. There's a possibility of infection, very rare possibility of a tumour, and a very rare possibility of a stress fracture. Traumatic elbow is a different animal entirely, but if we're looking at non-traumatic, it'd have to be a stress or a pathological fracture. Both of those, both the tumour and the pathological or stress fracture are rare. Infection is a possibility, so if you're going to go that route, you need to start thinking about taking temperatures, pulse rates, and looking for really weird stuff in the history. And with the fracture, you need to palpate the bone and possibly use high intensity ultrasound to see if you can reproduce pain over the bone. So it doesn't really matter so much in the elbow, but if you're looking at the neck, for example, a motor vehicle accident, it's possible they got a very high cervical fracture. C1 or 2, and they're still ambulant, but they've just got severe pain. So with a motor vehicle accident, it's a good idea to get rid of the possibility of this being a fracture. And you can do that through the history. In fact, you shouldn't be touching the patient until you're sure it isn't a fracture. So you're looking at things like sudden onsets of severe pain, central pain as well, immediate onset of a deformity, a torticollis, which could be a fracture, or it could be basically a landoaxial rotary fixation, a dislocation basically of C1 on 2. But in the elbow it's not that big a deal. In other areas it can be. So keep that in mind. If you want to rule out the more serious one with a null hypothesis, that's absolutely fine. So negative differential diagnosis. Now you've already seen this list earlier, but again I would list my differentials this way. And then we'll look at to see what tests we can do and what the negative test would suggest for that particular differential. In fact, the more sensitive the test is, the better it is for this. So if I've got a test that's 100% for the common extensive tendinopathy, and that test is negative, I know that it's not common extensive tendinopathy. Whereas if I'm looking at proving it, I need 3 or 4 tests to can come close to proving it. Basically, the essential illness script has to be present for me to prove that it's present, whereas a single test or a single question can actually say it's not that, or in all probability it's not that. We can come back to it later if nothing else is panning out. But for the moment, let's get rid of it and move on to something more likely. So this is the value of differential diagnosis. You can go through these things very, very quickly. Okay, so common extensive tendinopathy. This one is just about 100%. Palpate the tendon. If the tendon is not positive, and this applies to all tendons, and provided you can reach the entire tendon, then you can say you don't have the pathology in the tendon. It will be painful, it will be tender on palpation. Biomechanical dysfunction, negative elbow quadrants. It can't avoid it. There has to be a positive quadrant. Similarly, with any other arthropathy, the quadrants will be positive if you have one present and negative if you don't. So those 3 tests are almost going to be 100%. Interosseous neuropathy, no neuropathic pain, no neuropathic symptoms, only somatic pain. It isn't a neuropathy. LCL tear, palpate the ligament for tenderness. And a stress fracture, which as I say is extremely rare, you can palpate for bone tenderness. And finally, referred pain, all your local tests will be negative and will not reproduce the pain the patient is complaining of. All right, we've generated our first hypothesis, H1, right there. And we'll say it's common extensive tendinopathy. So we attack that hypothesis either with the essential illness script or any other method you want to use. But if you're going through the hypothetic inference, I'd suggest using the essential illness script. It's going to be much quicker, much easier. So we're looking for pain on gripping. The tendon, it's going to be tender to palpation. The isometric extension is going to be positive. Now let's assume that succeeds and that the essential illness script fits. We can then stage the diagnosis to tendinitis or tendinosis. We will then also attack this with error and bias correction, which I haven't bothered to put up here, but you go through the differential diagnosis. If you haven't already done that, and you probably have, so you don't have to worry about this, which then leads us on to etiology. Now, if H1 fails, then you move on to H2, whichever one you want. I want to assume it's biomechanical dysfunction. And again, you attack that hypothesis with the essential illness script. If that fails, you move on to H3, 4, 5, HN, until you get one that's good, and that will be your diagnosis. The more hypotheses you go through, the less likely is bias and error. So it's not a bad thing to keep coming up with a negative diagnosis until you actually want to hit the one. And the further into this process you are, the less likely this is going to be due to error and bias. Now, just a quick word on diagnosis here. I'm saying this is your diagnosis. It's still provisional. That diagnosis needs to be proven by the treatment that you prescribe for that diagnosis actually working. If it doesn't work, you've made one of 2 mistakes. Either the diagnosis is wrong or your treatment's wrong. And then you're going to have to look at the whole thing again, including what you treat it with. But you cannot say that diagnosis is correct until your treatment's worked on it. So it's a working diagnosis, and your final diagnosis is when it's better. That may still not be actually the real diagnosis. You may have got lucky making the wrong diagnosis and giving it an appropriate treatment. But that doesn't matter to you. The diagnosis you came up with led to the treatment and it worked for you. Okay, so I think what I'll do is I'll contrast this with the way you would look at the neck for looking at serious pathologies before you start looking at the mundane ones. And I'll do that one more slide before we finish on this. Okay. This is simply to compare hypothesis testing in the cervical spine after trauma with the elbow, even with trauma. You've got a lot more to be worried about in the neck than in the elbow. So we'll be talking about these conditions a lot. Don't worry about it as we go through the course. But right now I just want to look at the differences and show you that there is a difference. So we have a patient post-MVA complaining of neck pain, and we have to worry about three major things here. One is a fracture, then VBI problems, and also cord compression. So let's say the first one should be a fracture, because that's the one you can displace and do the patient's some real damage out. Now, this fracture, the one you're worried about, of course, is a high cervical major fracture that is inherently unstable and can do the patient a lot of damage, if not kill them. Other fractures are not as obvious as this. They will have similar sort of onset and so on, but they're not as urgent as this. For those ones, look at the Canadian C-spine rules and look for a breach in those rules. They should have had an X-ray at that point. But if you've got what appears to be a breach of the C-spine rules, they've had an X-ray, but they've also got the history suggestive of a fracture. It's probably just as well to get this back and ask them for another X-ray or a CT scan. Anyway, the EIS for all fractures, actually traumatic fractures, is an immediate onset of severe pain, probably the severest pain they're going to experience. The pain will be central unless it's a minor fracture, in which case maybe the transverse process, that may be unilateral, but that should be an immediate onset. So immediate onset of pain, severe central pain, and an immediate torticollis is very highly indicative of a major cervical fracture. In that case, that really does want to go to the emergency room, and it should be in a hard collar and preferably by ambulance. This is a major issue. Let's assume that we're not getting any of that from the history. We can move on to VBI. Now, again, you don't want to be moving the neck around. If they've got an embolus forming there, a thrombus rather, then you don't want to be knocking off emboli. So again, don't move the neck around unless you're happy that there isn't a problem there. So anybody with neurological symptoms, they have a headache and dizziness, which are the two major symptoms of VBI, not the 5Ds. These are the two big ones, and they're not even in the 5Ds, apart from the dizziness. So we'll come back to this, but if they're coupled together and both are uncoupled from the neck, this isn't a good thing. Get it out of there. And do a cranial nerve examination anyway. If that's positive, fire them out. If you're okay with that, you can move on to cord compression. So look for evidence of signs and symptoms of a myelopathy. Bilateral, trilateral, quadrilateral neurological symptoms. Looking for paresis, spasticity. This isn't going to be a quad. This is going to be somebody who's got some compression of the cord, but it's not obvious. So you've got special tests you can do, drop knee tests, rapid dorsiflexion, looking for clonic responses and so on. If you're okay with that, then you're probably okay to go and look for less serious hypothesis. But you can see how this particular hypothesis generation is completely different to one where you don't have these sort of serious conditions that you have to worry about. Okay, so we'll talk about this as we go through, and I hope this is helpful to you. Bye.